Hello, good evening. This is Professor Triple N or Nick PA from Brooklyn, New York. Today is April 7th, 2022. It's about 11 o'clock p.m. Uh, I would like to go with you over allergy and immunology board review sessions for mid-level providers, PAs, and MPs. And if you have any questions or suggestions, please feel free to email me at my email, which is very simple. Nick, like my first name, Nick, M like Mary, D like dog, the number one at gmail.com. Let's start from the first slide and discuss so-called anaphylaxis. By definition, anaphylaxis is defined as the worst form of allergic condition or acute event. Is synonymous to immediate hypersensitivity. The patient must already have been sensitized to this to this antigen. The IgE binds the mast cells, leading to release of the granules, which has a histamine, prostaglandins, and leukotrienes, which result in abnormalities, essentially, which is defined as anaphylaxis. Anaphylactic reactions are non-IgE related. They're clinically identical and treated by the same way and do not proceed with sensitization of the antigen. So there is two areas we need to pay attention. This is the respiratory and hemodynamic area of the anaphylaxis. By definition, there is a clinical tip here which states that anaphylaxis is defined as a severe, is defined by severity, not by the cause of the reaction. Let's go over etiology of anaphylaxis. We'll move to the next slide, slide number 2. In slide number 2, we need to discuss the causes of anaphylaxis. And the causes of any allergic event could be several. Number 1, insect bites and stings. Number 2, medications such as penicillin, phenytoin, lamotrigine, quinidine, rifampin, and sulfa, and foods. There is a clinical tip here which states that latex is a very important cause of anaphylaxis in healthcare workers. And there is a nice table here which explains the anaphylaxis. So we have sensitization, number 1, number 2, re-exposure, number 3, anaphylaxis, and the last one is death, unfortunately. In sensitization, we have initial sensitization of antigen. In re-exposure, we have, upon the re-exposure, Ig binds the mast cells, leading to release of the granules, which has two main components, histamine and leukotrienes, and the third one is prostaglandins. And number 3, anaphylaxis uh, presents in several ways: hives, itching, airway constriction, swollen tongue, wheezing, dyspnea, tachypnea, nausea, vomiting, diarrhea, dizziness and fainting, hypotension. And the last one is death. The presentation is, uh, clinical presentation is additional to the rash. It can be presented with any form of allergic reaction, such as hypotension, tachycardia, respiratory presents with shortness of breath, wheezing, swelling of the lips, tongue, and the face, and stridor. Let's go to slide number 3. Slide number 3 on figure 4/2, we see a example of urticaria with localized anaphylaxis with wheals and flares. There is a clinical tip here which states that urticaria is considered part of anaphylaxis. It is not just an allergy. The treatment is the following. The best initial therapy is number 1, epinephrine, number 2, antihistamines such as H1 blocker as diphenhydramine or H2 blocker as a ranitidine. Number 3, glucocorticosteroids such as methylprednisone and hydrocortisone. And the last one, number 4, emergency airway protection as needed, intubation or cryo. There is a clinical tip here which states that there is no specific test to define anaphylaxis. Let's go to the next slide, number 4. In slide number 4, we will discuss angioedema. By definition, angioedema, this is a sudden swelling of the 1 face, 2 tongue, 3 eyes, and 4 airway. This can be from deficiency of C1 esterase inhibitor. Could be associated with onset of the minor physical trauma. Angioedema often is idiopathic by origin. And there is a clinical tip here which states that look at the recent start of ACE inhibitors preceding symptoms. By presentation, hereditary angioedema is characterized by sudden facial swelling, stridor, with the absence of pruritus and urticaria. Hereditary angioedema does not respond to glucocorticosteroids. Let's go to the next slide, number 5. On a figure 4/3, we'll see a child with angioedema which has a swollen eyes which is shut down. The diagnostic test, the best initial test is to look at the decreased levels of C2 and C4 in the complement pathway, as well as deficiency of C1 esterase inhibitor. There is a clinical tip here which states that a K1 is a specific therapy for angioedema. It's difficult to pronounce. Ecallantide, ECALLANTIDE. And let's discuss so-called the treatment of angioedema. The acute therapy includes fresh frozen plasma, ecawantidine, or icatibant. Number two, this is number one. Number two, ensure the airway first. The process can evolve rapidly. Number three, urticaria. If respiratory compromise or urticaria are present at the outset, use epinephrine, antihistamine, and steroids. And then number four, C1 esterase inhibitor concentrate, the best initial therapy for hereditary angioedema with severe laryngeal involvement. Recombinant C1 inhibitor concentrate is the alternative. Let's go to the next. Let's discuss so-called urticaria. This is a form of allergic reaction which causes sudden swelling of the superficial layers of the skin. In addition, this could be caused by insects or medication. Urticaria also can be caused by physical agents such as pressure, cold, vibration. The treatment is antihistamine, number one, and number two is leukotriene receptor antagonist. From the first one, first group, we can give a patient hydroxyzine, diphenhydramine, or phenolphenadine. And from the second group, we can give montelukast or zafirlukast. Let's discuss allergic rhinitis. And the etiology, we need to go to next slide.